Apnikan sobke swagat kori ase Hornbill TV re moi Mercy Konyak aru itia nagamis khobor janai di ase Indian Dental Association Nagaland State Branch laga 18 Conference General Meeting kali para shuru kurina aji 2 din hoise agere program logina nishina itia bi relaxation jari jase itia live program jari na sawo moi khan sob
took me 20 years to understand that sticking to a good brand is sensible rather than try to save money with cheap brands. And it took me 25 years to really start teaching and confidently saying that what I'm doing in my clinic is correct. Just follow it blindly. You will not go wrong. This is my first slide always because I want the sound piece. There's no sound. So I am extremely proud to show off my country whenever I lecture abroad. And I have always realized that what brings us together is amalgamation of cultures. Every other country has one religion, one type of people. It's a carbon copy, every city. But in our country, everything is different. And that is my speciality, and with that, I would like to salute you and go ahead. So these are a few of my cases which I have done over the years, and let me tell you that oral surgery is one of the most gratifying branches of dentistry. I always wanted to do oral surgery. I wanted to be a surgeon. My parents were very old-fashioned. They didn't want me to go out of Bombay, so they said, okay, go into Nara Dental if you don't get into medicine. So then I decided that I would go for oral surgery. And when you save dentoalveolar fractures, you restore teeth, you fix the asymmetrical face with orthodontic surgery, you take away pain of a third molar, you take away a cyst, whatever you get, the gratification or the blessings that you get, it's unmatchable. Also, what I have realized is that the person who comes first is not necessarily the most successful practitioner, but it's the person who works hard, right? He might be a BDS, he might be a hygienist, but he might make the most money. So don't be under this impression, oh, MDS earns more money, I should have done MDS. Nothing like that. Keep attending courses, keep learning one new thing every year, and you will soon be at the top of your profession. So this is what I'm going to be teaching you. And again, like I told you, it's going to be 1, 2, 3 and go. Just blindly copy what I'm telling you. It will work. So what are surgical skills? See, surgical skills are the foundation of every branch. All of your localities must be having one fantastic general practitioner. सब भीड़ उसके पास ही जाता है. Why? You ask a lay patient, oh, he gives a vaccine, you don't feel it at all. He gives a tetanus shot, you don't feel it at all. The hand is so gentle, right? What do patients remember? How gentle your hand is, how painless the procedure was. Bhale you call him 20 times or you finish a root canal in 1 time, but if that root canal pains in 1 time, that local anesthesia only pains in that 1 time, he will not appreciate ek sitting mein khatam kiya. He will say dhire dhire karna tha, kitna dard diya. Right? So what is surgery? Surgery is as minuscule as giving local anesthesia. Your hand has to be gentle, and it's the foundation. Once you're convinced, 10 patients tell you, doctor, your hand is very gentle, then you can be confident that your work in all 8 branches of dentistry will be liked by the patient. So this is what you're going to take away today, right? All these topics I'm going to be covering. Now, coming first to treatment plan. What is our objective? Is there a problem? What is interfering? Oh, but why is the audio not coming? Because I've got video. Can you hear me, guys? Yes. Okay. Yes, volume. Yeah, so I don't know. So the treatment plan is here. Right, so what's our objective? Short operating time, minimal trauma to the soft tissues, adjacent teeth, and of course a painless procedure, no complications. Right, no complications is most important. Now painless procedure, that is such a grey matter. Can it be painless even if you apply the topical anesthesia? Thoda to prick lagne wala hai. So here I would say, don't promise the patient painless procedure. Say, I will be very gentle with you, trust me, it will be, COVID shots have made it very easy for us. It will be just like a vaccine. Everybody's taken the vaccine. Earlier when you say it will prick you a little bit, they'll say, oh, dukhega. But now when you say it will be less than a COVID shot, they'll say, ah, COVID ka kuch nahi hua. Right? So you say it will be less than a vaccine. Sometimes I live in my practice is in an area which is close to all the film studios. So I get all these stars coming to me. And the female stars, oh God, they are nakhras. So now I have started telling them that you do Botox. They open their mouth. I said, yeah, I can see you've done Botox. That didn't hurt. So this is going to hurt lesser. This is not a haircut. You've come to take a tooth out. You've come to do a root canal. You've come to do a flap surgery. So it is going to hurt you. After that you will feel pressure. Hold their arms. Hold their arms and squeeze and say, is this pain or pressure? They'll say this is pressure. So say exactly. So you will feel this. Now if you insist on saying ye pain hai, I cannot do anything about it. I have not made you unconscious. I want you to talk to me. I want you to communicate with me. So you will feel pressure. You will feel pain only when I am anesthetizing you, and that will be for a few seconds. So you say like that. So after that, once itna counseling kiya, then even if the LA pains, the patient won't lose trust in you. Okay? You say painless, and then they'll go outside and talk about you kitna pain kiya. Okay? So what are the 5 commandments? Establish correct diagnosis. That's very, very important. Right? Does it require surgery? And once it requires surgery, our planning has to be perfect to the last detail. Then of course comes sterilization and proper instrumentation. Sterilization is very important. We don't want outside infection coming into the patient's mouth. Right? We are supposed to take out this thing and follow-up care of the patient. In surgery, follow-up care is very, very important. Every alternate day, what is that sound? Okay. I'm not doing anything wrong. Okay. Every alternate day, you have to call the patient for flushing, checking, all those things. For one, you come to know whether the patient has a swelling, he's going into dry socket. The other, in the patient's mind, surgery is a big word. Filling is not a big word. Scaling, polishing is not a big word. Right? But any surgery you say, even if it's surgery karke nikalna padega daant, it's a big thing. 10 relatives will be told by evening that I got a dental surgery done. Right? But no one will inform anyone if they get a cleaning done. Right? So, you should call them 2-3 times and check that what you have done is proper in the mouth. The patient has not started eating pan, supari and all that, has not spoiled your surgery, the sutures are not open. So that builds a rapport with your patient. At the same time, you can prevent secondary complications. Now in establishing diagnosis, history of the patient extremely important. Medical history, dental history. In medical history, it's general physical. A patient walks in, just take a look at him. Fat hai, short hai, flabby hai, is he panting, gasping? Means diabetes ho sakta hai, blood pressure ho sakta hai, right? Does he have patches on his hands? You know, it might be leukoderma, autoimmune disease, right? Is she walking very slowly? Is he limping? Arthritis, rheumatoid arthritis. So generally get an idea as the patient walks into it. Extraorally check where the swelling is. When the patient says, I've got a swelling here, I've got a swelling here, I've got a swelling here, right? So understand where the swelling is. I've got swelling here. So if a swelling is here and patient has come to you, you know it is a psychological case. You're not supposed to take it. Swelling here cannot be because of you. Right? So just observe all these things. Intraoral varies. Check the complaint first, then look at the everything else in the mouth. Never assume, always ask. Even though you can feel some mucus fibrosis, it can be hereditary also. Ask the relative. पान खाता है, सुपारी खाता है, 15 साल पहले खाता था, 20 साल पहले खाता था, स्मोकिंग करता था. Always find out. Family history of diabetes, family history of cancer. Patient has come to you with ulcer which is not healing for 1 month. Do you prescribe Kenacort and tablet for a while? No. You first ask the patient history of diabetes, history of smoking, history of parafunctional habits, and family history of cancer. It can be cervical cancer, it can be breast cancer, it can be any cancer, blood cancer, whatever. Then taking a biopsy is a must. Because if it was a normal ulcer, it should have healed in 1 week. Right? And take a biopsy, it will come no, but at least it's on record that you did not neglect that lesion. Right? So, this is very important, and now medical history is why important? Because of COVID. Because in COVID, patients were given steroids. Patients were given very strong antiviral drugs. All this gets the patient's immunity down to 0. Trust me. And many of them, I don't know how it is here, how it was in your state, but in Bombay it was very, very bad. Patients are still complaining of long COVID symptoms like fatigue, lethargy, body ache, knee pain, and dry mouth because of all the medicines they took. Even 1 year after they had COVID, 20 mein hua, even now they are complaining of dry mouth. So this is because of COVID medication. We can't do anything about it, right? We can only tell them that chew vitamin C. Right? So taking a proper history is very, very important. Now, if a COVID patient says he was given steroids for 1 week, if he was given steroids for 1 week, 1 year back, you do nothing. You go ahead and do the treatment as it is normal. If he was given steroids 8 months back, you do nothing. But if he was given steroids for 15 days, even as far as 6 months back, then you must call the family doctor, and in Bombay at least the family doctor is advising us to start the same steroids 2 days before any long dental surgical procedure like an implant or like a surgical extraction or even multiple root canals. Why? Because the patient's immunity without steroids is 0. So even if you do a root canal where a normal patient will feel 0 pain, this patient will be holding his jaw for 4 days because his tolerance capacity is 0. The body requires the petrol of steroids to get its immune system working. So you should always call a physician when you take the medical history and it is COVID positive. Ask whether steroids were taken, if they were taken, and if it is as old as 6 months, then start the same steroids 2 days before the treatment and continue in a tapering dose, sloping dose, decreasing dose 4 days after the treatment. Alright? Now what is treatment planning mistakes? Incomplete history. You don't take a proper history, the wound is not healing. It's diabetes hai, pata hi nahi. Patients are taking ecosprin, they don't take. नहीं वो तो 15 साल से ले रहे, वो छोटा सा गोली है. अरे छोटा सा गोली है, उसकी वजह से तुम मर गया मेरे क्लिनिक में. Are you going to tell that to the patient? Right? Because he is bleeding like a tap. Right? And he forgot to tell you he was on ecospray. Then it's better to take investigations. Right? I got a shock of my life when after I did a fracture, the wife tells me, dentoalveolar fracture, that मैं मुझे भगवान समझती थी, आप दूसरे भगवान निकले, आपने मेरे हस्बैंड को ट्रीट कर दिया. So I didn't understand what she meant that मैं मुझे भगवान समझती थी. So I said, आप क्या बोल रहे हो? So she said that he is HIV positive. So I had done the dentoalveolar fracture in my clinic under sedation. So if you go to a hospital, you have to compulsorily do HHH tests. But in a dental clinic, you just ask that, do you have diabetes, do you have heart problem? And obviously you're embarrassed to ask, aapko HIV hai kya? Right? So you don't keep quiet. And that man smartly didn't tell me. And the wife thought that he had told me. So what the wife meant was that I have not divorced him even though he is HIV. So I am a goddess. And you treated him in spite of him being HIV. So you are the second goddess. Oh God, how much I prayed that night. I didn't tell my family at all. After 8 days, I quietly went to the laboratory and got myself tested. After that, 2-3 gloves, and I couldn't say no to the patient. I had to remove the wires also. Then I kept him as the last patient of the day. Then I fumigated. I changed my suction tubing, everything. All that happened, but those 15 days were full of tension. I was coughing. I was like, I mean, my husband was really happy. She was saying, why is she having a headache for 15 days? What could I do? I wanted to keep him safe. That way. So inadequate infrastructure, like if you don't have surgical instruments, don't do it, right? Because if you're left with a broken tooth, then your reputation is gone. Don't try stunts. Your practice can be ruined by one patient, and it takes 5 happy patients to make a good practice. But one unhappy patient to bring it all to zero. Now this is very, very common, and I purposely put this slide here. Many patients have clicking of TMJ, and the general dentist refer the patients to me, remove the upper third molar. The upper third molar has got nothing to do with clicking of TMJ. Clicking of TMJ and headache is because of bruxism. The patient is clenching. The articular disc has slipped out of position, right? And he requires physiotherapy and muscle relaxant exercises. But removing the upper third molar, taking that flap and etc., it's going to create more problems for him. So leave such upper third molars the way they are. Don't think they are the reason for his headaches or for his pain. Another thing patients tell you is that I have got sharp shooting pain and they cannot zero down on the pain, right? They cannot say this pain, tooth or that tooth or fourth tooth. And dentists say, okay, first they try root canal, the pain has not gone. Then they ask for CBCT, fracture hai kya? There is no fracture, pain has not gone. Then remove the tooth, okay, pain is still there. Why was the need? The pain was neuralgic in nature. Was it on the other side? It wasn't on the other side. So you should always, when there is no POP on a tooth, when the X-ray does not show any pathology related to a tooth, when CBCT does not show any pathology related to a tooth, then please don't think the tooth is responsible. It can be TMJ, it can be neuralgia, it can be muscular. Earlier, in the earlier generation, we used to bite our nails and we used to crack our knuckles. Those were our stress relieving tactics. Now socially we have become more sophisticated, right? No one can be seen cutting their nails or biting or doing these things or scratching their ears. So what do? We take all that stress inside. We clench our masticatory muscles. We clench our temporalis. We clench our trapezius. We sit rigid. We clench our teeth. All this leads to sensitivity, fine vertical fractures, cracks, neuralgia type pain, right? But it is not tooth related. So taking a proper history and making a correct diagnosis is very, very important. Otherwise, you will really end up doing something criminal to the patient. So what I have done is a history form in the local language. I have made it like this in a detail, because if you ask the patient to write the history, no one will write the history. So I have only written the history. All the patient has to do is read it and tick. Cross or tick. So that becomes easier. And the title also, it is not complicated. Cardiovascular. Who understands cardiovascular? Chhati ka bimari, pet ka bimari, heart ka bimari. Just be simple. Skin problems. Something like that. And then take the signature. Now this is a consent form given to me by a Supreme Court justice. Please take photographs. See that informed consent, what you see out here. Right? This wording is important. This says that I have been told the procedure in the language I understand and I consent to it. Now, there will be different complications. It can be paresthesia, it can be, implant failure, it can be crown fracture in case of a bruxer. So whatever the treatment is, you just write in pen out here, right? After you get the signature of the patient, right? Don't write patient will die also and then tell the patient sign. He will not sign. Okay? So take the signature first and then write in pencil here, so and so treatment plan, explain to the patient, possible complications. If it is a upper implant, chronic sinusitis, implant failure, nasal perforation, right? Just write these three. So these are the common, so that way you have it on record and the patient can't legally damage you. Now radiographs are extremely important, and when you look at the radiographs, learn to read the radiographs. Don't just look at it two-dimensionally. A student broke this premolar. It was lingually tilted. She thought that she could take it out with just elevation, but she made a mistake. Why is that? See the apex of the neighboring tooth. See this apex. It is conical, it is sharp, and see the apex of this. Can you see this? It is rounded. And can you see this apical foramen? So it is curved into the buccal cortex. Right? So it is dilacerated into the buccal cortex. So even if she would have pulled with both her hands, the tooth would have fractured. What this required was take a flap, approach from the buccal cortical blade, cut the tooth and take it out in two pieces. So learn to read the X-ray. Now of course CBCT has made it much easier. Again, upper ear. Is this a simple extraction? No, because can you see this? There is bone out here. Right? When you go to extract this tooth, the tuberosity is going to come out. So don't panic. You know, no need to inform the patient, because breaking a tuberosity is no big thing. Right? But you know tuberosity is going to come out and you need to exert more force. OPG of course is a must. The patient came with pain in 7. I suspected 8, but I never suspected a cyst. Right? So taking a OPG is must, and CBCT helps us where it is in the center of this, of course for implants, but even for tooth extraction. What happens is, when you see this orange tube, right, it becomes easier to explain to the patient. How do I explain to the patient? I say, can you see? I have seen hundreds of patients, but your case is a little abnormal. Always say your case. Don't say it might happen by me. Say your case is a little abnormal. Your nerve and the tooth are very close to each other. So when the tooth comes out, the nerve will take some time to settle down in the position. So you might have paresthesia for a few weeks, for a few months. Don't say the possible complication of this surgery is paresthesia. Then the onus comes on the surgeon. तुमने surgery बराबर नहीं किया. Right? Have you put the tooth there? Have you put the nerve there? The patient's, it's the patient's fault. Patient's abnormality. So CBCT is very good at explaining to the patient that look, it is an abnormal situation in your mouth, but I am experienced enough to handle it. I am confident of handling. It's my duty to inform you of your abnormality. So I am not telling you. Please keep calm and trust me. Now coming to sterilization, honestly speaking, if you are doing implants, then a phase B autoclave is a must, right? But if you are not doing implants and if you have a simple practice and the implantologist comes to your clinic, then even this steam autoclave is enough. This has to be there in your clinic, ultrasonic cleaner to clean all your burrs and everything, especially after all these viruses have come into the picture. UV light sterilizer, all your diagnostic instruments should stay in this UV light sterilizer so that they stay sterile even after autoclaving. And everything should be in sterilization pouches. Even mirror tweezers, mirrors also, don't put them in a betadine solution or a sterilium solution. It has to be made into this pouch for your safety and the patient's safety. Contamination in surgery is leading cause of failure. It's the leading cause of dry socket. It is the leading cause of delayed healing. So every week fumigation of premises is extremely important, and infected cases should be taken last. Means even if a patient comes with an abscess and you have to do a simple 5 or 6 extraction, don't take him as the first case, because pus niche girne wala hai. You are going to clean the clinic, you are going to do everything, but even then there is a chance that anaerobic bacteria will be moving into your operating. So call such patients last at the end of your working day. After that, clean the clinic completely and then start your next session. So what is the basic in oral surgery? Scrubbing, draping and painting. And there are 3 different agents to be used. Betadine mouthwash is for gargling. It is not for cleaning the face. For cleaning the face, you have a scrub. Betadine scrub. In betadine, our gloves are sterile, but are the cartridges and the needles sterile? You take it out from the Septodont box, right, and you load it with your autoclave gloves. What is the point? So before any surgery case, you must soak these cartridges and needles at least for 15-20 minutes in a betadine solution. Everything should be covered with a sterile drape. Right, wherever your fingers are going to touch. Even this light handle, can you see this light handle? This is a very good technique. What I do is, अपना खाने का foil होता है ना, that foil you cut into A4 size paper. You fold it, you put it in a blue pouch like this, right? And you autoclave about 12 at a time, and nothing happens. And once you are preparing, then all these light handles, table handles, handpiece, suction tubing, you just, instead of plastic sleeve or something, just twist the sterile foil around it. So it is cheap, it is easy to do it, and it is disposable. The doctor, what I do is I first inject. So while the injection is working, while the anesthesia is working, then I drape myself. When I am injecting, I will use examination gloves. But when I am operating, I will use this. When I am injecting, that's when I will adjust the table, the light. I'll instruct my assistant where to stand, so that once I wear my examination gloves, my hands touch only the mouth of the patient and the instruments. No mobiles allowed. Behind your back, your assistant must be WhatsApp, right? So be very strict. Even the patient's mobile should be outside. Now let's come to local anesthesia, right? So it's actually rest from pain. A patient will remember you if you take his pain away in the first shot, right? So what is local anesthesia? It's a loss of sensation in a small area of body for a small period of time, right? What happened? Yeah. And what are the different types of anesthesia? We've got local, IV sedation, general by the nasoendotracheal tube, that's in the hospital, usually done by oral surgeon. But I don't know what it is in your state. In our state, we can call qualified anesthetists to our clinics for pedo patients and old patients, and we can give conscious and IV sedation like this on a dental chair legally, and we can do it. The drugs they use are fentanyl or propofol. In 1 hour, 2 hour surgery, we can do that. Excuse me. I'm sorry about this. So let's see. Let's see how we can give a patient local anesthesia and yet keep him happy. Something about the history, right? The ether was the first anesthetic drug that was discovered. And why is local anesthesia so important? Because that first shot is your last shot at impressing the patient. The patient will go home remembering how painless that shot was. Right? So what do you first need? You need first topical anesthetics. Please don't go in for cheaper brand. 5 years back, in my 21st year of practice, a local dealer came to me and told me, please help me. I have started a factory in Panvel. I'm making this fantastic vanilla, strawberry, pineapple colored topical jelly. It's an exact copy of this. It smelled so nice, the box was so nice. I thought, let me use that. I used that on the first patient and I started arranging my instruments. The assistant just tapped me on the shoulder and looked at the patient. The patient's lips had turned blue, patient's eyes had got swollen, face had turned red, and patient was trying to breathe but couldn't breathe. And he was trying to vomit but he couldn't vomit. He had gone into immediate anaphylactic shock. I gave him injection Avil intravenously immediately. I gave him injection hydrocortisone immediately. What is it? Why was that jelly so cheap? Because there was more of flavor in it, there was more of Vaseline in it, there was less of local anesthesia in it. right? But this, if I was not an oral surgeon, if I did not know how to give intravenously, the patient would have died by the time the ambulance would have come home. And trust me, this happened not in my first year of practice, in my 21st year, 5 years back. So you can still make mistakes. So always buy brands which are FDI approved. They may not look attractive, they may not have a fantastic flavor, but buy brands which are approved by the American Dental Association or our FDI, right? Now this spray, many people say that the spray goes in the patient's throat and patient starts gagging. So there's an idea to that. What you should do is, you should spray on a cotton ball and you should place it where you're going to infiltrate or where you're going to give a block. Ask the patient to bite on it for 30 seconds. The mucosa becomes numb. Don't spray it because then he will say, I can't swallow, I can't swallow. Then comes the syringes. If you're using vials, you will obviously use these disposable syringes. If you are using cartridges, you will use the autoclavable stainless steel syringes. The difference between both is that the disposable syringes you can aspirate. In olden days, the old cartridge syringes, you could not aspirate. But now, Septodon has come up with these aspirating syringes. How do you know they are aspirating? That piston hota hai na? Piston will have a prong like a fork or an arrow. It will pierce the rubber stopper and you can withdraw the rubber stopper, and if blood comes out, you know you are in a vessel, so you should withdraw the needle and you should redirect your syringe, right? So this is the best thing that has happened for cartridge users. Always buy aspirating autoclavable syringes. Needles, always remember that 30 gauge, 1 inch is for infiltration. 27 gauge, 1.5 inch is for blocks. And 18 gauge, disposable one is for flushing, right, for irrigation. I had a student from Patna. He kept telling me, "Mera block lagta hi nahi hai, mera block lagta hi nahi hai." He sent me videos, everything. I said, "Sab to barabar hai." Then I noticed, I asked him, "Which needle are you using?" So he told me that you get 5 cc syringe, disposable syringe. In that packet only that needle is there, right? That is cheaper than buying needles separately and syringes separately. So to save cost, he was buying that combination packet. The needle which was coming with a 5 cc syringe was 1 inch. Now how will a 1 inch needle reach the mandibular foramen and give a successful block? So then I had to tell him, please stop using the combo packets. Buy the 5 cc syringes separately, buy these needles separately. These needles separately, right? Never use the needles which come with the syringe. They are the cheapest quality. They are 24 gauge. एक तो बहुत जाड़े होते हैं, right? And they are 1 inch. They will always hurt the patient. So 27 or 30 is the gauge to be used for oral mucosa. Very important. That will, these two will not hurt the patient. And when you do this, when you inject, bevel should always be facing up. What do you mean bevel should be facing up? See, this is the bevel, right? So the tip will touch first and then it will go in. Don't hold it upside down. You wear loops for your aesthetic work, you wear specs, you wear magnifying glasses, but whenever you inject bevel facing you, away from the gingiva, and don't drag the needle like this. Many times you will realize that wherever you give LA, the patient comes with an ulcer in that area. Right? Why has that ulcer formed in the area where you have given LA only? Because the mucosa moved when you were giving that LA. And the tip of the needle abraded the epithelium. That fine epithelium thoda scratch hua, patient got ulcer in the vestibule. Right? His tooth is okay, but the ulcer is troubling. Right? So your needle should be bevel up and single straight shot. Don't drag the needle. Now what should be the property of a LA? Action should be reversible, painless, non-irritating, allergy-free, and it should get excreted also fast. You don't want the patient to be in LA for 24 hours. You will wonder what has gone wrong. Right? So now let's see, these are the drugs which follow all those standards. So we have lignocaine cartridge with adrenaline and without adrenaline. Frankly, don't break your brain too much about 1:100,000, 1:80,000, all that, it doesn't matter. Right? 200, it's a very minuscule amount. Right? So you can buy any. If the cardiologist says don't use adrenaline, then use LA without adrenaline. Otherwise with adrenaline, 200,000, 100,000, 80,000, anything you can use. Now without adrenaline, in cartridge you have mepivacaine, right? And with adrenaline you have articaine and lignocaine. If you are using vials, you have bupivacaine without adrenaline and ropivacaine. Both these unfortunately are without adrenaline. Now what are the advantages of keeping these other agents also in our clinics? Because it can be used for patients who say they are allergic to lignocaine. These drugs, they last longer than lignocaine. And actually they work better when there is periapical granuloma, pus present, in gingivitis, wherever there is anaerobic bacteria present, right, or a serous collection present. So you must have the alternatives with you in your clinic. Now what is the whole point of adrenaline being there? Adrenaline causes vasoconstriction, it increases the speed of anesthesia, so faster action. Right? So we have these two plus points for adrenaline. Negative points are because vasoconstriction, and if the patient is a cardiac patient, enough blood won't reach his heart. Right? So in such cases, what do? Wait for a longer time, because otherwise the patient will feel pain. And don't use only lignocaine. Use lignocaine and mepivacaine, or lignocaine and sensorcaine, that's bupivacaine. Combine both of them to get the desired long effect. Otherwise, the effect will not be profound without adrenaline. Is a test dose necessary? If someone comes and says that, oh, I'm allergic to 10 things, then you better give a test dose and say, this is the first time I walked into a dentist's office. Then better give a test dose. How do you give a test dose? On the forearm, hairless area. Take a needle, a separate needle, right? Just inject 2 drops. And it is very easy to convince the patient. Say, I don't want any complications happening, so I want to do this for you. Don't worry, the patient is okay. Just the size of a mucosa, right? Wait for 1 minute. If nothing has happened, no urticaria, patient is fine, then go ahead. What I do is, I give a oral test dose. So oral test dose, just 2 drops, where I am going to be giving my drop. Just 2 drops. Can you see the blanching that is happening? That whiteness that is forming? So I know the mucosa has got those 2 drops of LA. Right? Now wait. Patient doesn't scratch his hands, lips have not turned blue, patient has not gone into a syncope, then you are absolutely fine, go ahead. And the advantage of giving the oral test dose is that my block area has become numb. So now when I give a block, the patient is not going to feel the pain. right? And no need to explain the patient why I am giving another injection here, right? So do this quietly, serenely, and you will get the idea. What is the maximum dose of lignocaine? In a 70 kg adult, approximately 15 ml you can give, and without adrenaline 10 ml. Now 15 ml is what? 15 ml it will be lignocaine 5 ml plus bupivacaine or articaine or whatever. Don't give 15 ml of lignocaine and 15 ml of bupivacaine, right? So total 15 ml. What really works at not getting the patient to feel any pressure is intraligamentary. Just bend your needle at right angles and inject into the papilla in the cervical gingiva. You will get a blanching effect. If you get a bubble effect, means you have infiltrated. You don't want to infiltrate. Infiltration you have already given. Now you will give intraligamentary from papilla to papilla. So you will inject here, you will inject on top, and you will inject here. Similarly, you will inject on the palate. Just very close, 1 millimeter from the cervical margin into the attached gingiva. Wait for this whiteness to appear, then the patient doesn't feel anything, whatever procedure you may do. Right? So giving intraligamentary is a must. And what do? I give a block with lignocaine or articaine, and I will use another drug to give intraligamentary. So I'll give intraligamentary with bupivacaine or mepivacaine, so that I have the benefit of all the drugs. Topical application is a must, because that really numbs. This is a splenectomy patient. So just like Amul butter, keep spreading it for a good 30 seconds. Right? Only then it will work. Infiltrations. Do you infiltrate here? It's not going to work. You have to infiltrate near the apex of the tooth. Right? So retract the lip properly. Check on the X-ray. Understand where the apex of the tooth is and infiltrate at the apex. Only then your infiltration will work. For buccal infiltration, when you infiltrate, you are supposed to massage, right, that area so that it spreads within the tissues and does not go straight into the circulatory system. Right? Now let's see how an intraorbital block is given.
Intraorbital block, we have to inject the LA in the mucosa opposite the second premolar, approximately 0.5 centimeter from the buccal surface. I'll show you how, but first draw a straight line from the pupil to the inferior border of the infraorbital ridge, second premolars and the mental foramen. This is the line which will go through second premolars and the mental foramen. The infraorbital foramen will exactly come in that line. Now for the needle, you will retract the lip, go from the second premolar, insert it in the vestibule. Your finger, your middle finger will retract the lip, your index finger will be on the approximate position of the infraorbital foramen, and you will feel the needle as it goes in. Once you feel the needle, hit the bone and inject. It is parallel to the second premolar. This is the intraorbital block, and this is the preferred block by even plastic surgeons because it anesthetizes the entire skin mucosa over lateral to the nose, inferior to the eye, and superior to the upper lip. So this is the position of the needle,
and you will feel the needle if you have retracting. See, this is where it should go. So you will get anesthesia from central incisor to second premolar. So this block is important if you are placing multiple anterior implants, if you are doing a dentoalveolar fracture, you are placing a zygomatic implants, or if you are doing crown cuttings. Right? So give this one block and the patient is happy and calm. Now nasopalatine block, how do you give it? From canine to
patient opens his mouth wide, he can be in a supine position. I'm showing the nasopalatine block. Hit the incisive papilla, the palatal side. You hit bone, withdraw slightly, jiggle the needle a little bit, feel it going into the canal, then curve the needle or bend your syringe so that the needle curves according to the arch of the palate. The canal follows the arch of the palate. You will feel the needle go into the canal. It will go in about say 0.25 centimeters or 2-3 millimeters. Inject about 0.25 ml of your cartridge and you have anesthetized the palatal mucosa from canine to canine, or most probably.
Just check the blanching. And what is important is that follow the curve of the palate. Right? If the palate is V-shaped, then your needle will go like this. So you will not hit the bone. You will enter into the canal and not much anesthesia goes in. Just half cc is enough. That's enough to give that wonderful blanching what you see from canine to canine. Okay? How do you give palatal painless? The backside of a mirror handle. Press it over there. The patient focuses on the pressure by the blunt handle and does not feel the pain of the needle. And always give it below the rugae. Right? If you give above the rugae, it's very, very painful because the periosteum is very tightly stuck over there. Similarly, posterior palate, it's just before the soft palate, not in the soft palate because the patient will start gagging. So just ahead of the last molar, in the mobile mucosa below the attached gingiva. Inferior alveolar block, again 1.5 cc, feel the mandibular notch, then you go parallel to the medial surface of the mandible, right? Turn the needle again on the opposite side, second premolar, inject the rest of it. Right, so you will feel bone in your first cross, in your second cross. You will feel bone on from when the needle is on the opposite side. When the needle is on the same side, you will not feel bone because you are going parallel to the medial surface of the ramus. And after you do that, even here I will end up giving a intraligamentary block. It is a must. Intraligamentary I will give all around the wisdom tooth. Right? That is a must. Now direct block. If suppose the patient has trismus, right? How do you do it?
The needle goes from the opposite side. This side, above the second premolar, goes in medial surface of the ramus and it should hit the bone above the mandibular foramen at the neck of the condyle. Hit the bone straight, 3 ml at least, inject completely after aspirating and withdraw. You may give buccal infiltration after checking for symptoms.
Again, this is a must. Now let's come to a alternative, that is RTK, right? Now lignos cane frankly is passing. Whoever is using cartridges are using RTK cartridges for a number of reasons which I shall tell you. Right? It is not very old. It is as it was name came in 1984. Right? And it can provide excellent relief even for oral surgical procedures such as zygomatic implants in mucormycosis patients and multiple implants, whole mouth cases also. So why is that? With a pKa at 7.8, articaine has a faster onset. Means if it takes 7 minutes or 10 minutes for lignocaine to act, articaine acts in 3 minutes. So you can start the procedure faster. Now let's understand where pH comes. pH, our body is alkaline pH, right? Pus and all that is acidic. So lower the pH, that's bad. You should have a pH as close to the body pH as possible, right? And if you inject a solution with a very low pH like 3, 4 or something like that, then it will take a long time to act. That's when the patient feels the pain of the needle going in. Then tissue damage also occurs because the solution is thick and it is going in, so it stretches the fibers and the patient develops trismus, right? And ineffective because it has gone straight into the system. So we have to have solutions which have a higher pH than 4, right? This brand has articaine, has 4.0 at the time of expiry and maximum is 5.5. So there is no pain when it is being injected. Also it is safe for the patient, especially in kidney and necrosis and cirrhosis and all that, because it is 4 times more liposoluble. It lasts longer. So supposing in the middle of a 1-hour procedure, by 45 minutes, patient starts complaining of pain. If you give articaine, the patient is comfortable for 2 hours. Degradation, again, because it contains an ester function, it has the shortest half-life. So it gets passed off in the urine and stool also very fast without damaging the liver and the kidney. Now, why do we prefer? Let's see the comparison. Lignocaine is 90 minutes, mepivacaine is 110 minutes, while articaine is only 30 minutes. So many times kidney transplant patients, dialysis patients, they are doctors, they don't understand dentistry, right? Even if we tell them 5 ml dene wale, they'll say no, prolong the procedure. The patient is in pain, we are losing money, they don't care, right? So when you tell them you are using articaine, they read about articaine and they read this, that it has degradation only in 30 minutes, then they say alright, go ahead and take the patient. So this is very, very important. Now what is the safe anesthetic dose of articaine? You can use up to 3.5 to 4 ml for buccal infiltration or just 1 cartridge for block. And in maxilla, you can use 3/4 of a cartridge as buccal infiltration. That much is sufficient. In fact, when upper 8, if you give buccal infiltration, you don't even have to give palatal infiltration. The spread is that much more, right? So you give buccal mesial papilla, you give distal papilla, you give distal to the tooth, you don't have to inject the palate. The same for all the molars when you are doing root canal. If you give buccal and if you give intraligamentary, you don't have to give lingual or palatal. So what are the benefits of articaines? Faster onset, higher potency, longer duration and better safety in medically compromised patients. In between, Bombay mein halla macha tha that don't use articaine. Kyun? National Health Service of England has forbidden doctors from using articaine because it causes paresthesia. Studies were conducted and it was realized that it was not articaine which was the reason, it was wrong technique, right? So this is the latest in Nature. Nature is the best medical journal. Nature, Lancet and PubMed. These 3 are the best medical journal It came in nature that in randomized controlled trials, which are the best, where the patient is not told which one is he being injected with, lignocaine or articaine, there was equal number of paresthesia in both lignocaine and articaine patients, not just in articaine patients, and the blame was on the operator fault, right, or the abnormality of the nerve position after taking the MRI. So, you can definitely inject articaine for locks and be safe. Right, now let's see what is allergy to local anesthesia. Allergy is rarely to the drug. It is usually to the preservative, that is methylparaben, latex and contamination of vials. Latex, all of us are allergic to latex gloves also. Right, we use nitrile gloves. So that rubber stopper of a vial is made of latex. Indian cartridges have the latex rubber stopper and it can come in micro particles. If that gets into the patient's body or that gets touched into the patient's body, allergic reaction can be seen. Again, methylparaben is there. So like in my case where I got that topical anesthesia anaphylaxis, maybe it was a methylparaben inside it. That's Vaseline. Septodont products don't have this, right? And how do you avoid this? See, use cartridges, they are latex free. Don't use vials. Even Astra ADL vials, unka jo buch hota hai na, that stopper, that is of latex, right? And cartridge may only thing is one cartridge for one patient. Even if you end up using half a cartridge, throw that cartridge away. Don't keep it, I can give intraligamentary with it, right? So one cartridge every patient, and if you are using vials, then you have a habit of pushing one needle in the vial and using the same needle continuously till the vial becomes empty. Like you use a different syringe, but the needle inside the vial will be the same till the bottle becomes empty. That's wrong, right? It should never be exposed. After every patient, that needle should be thrown and that plastic stopper which is there, it should be kept back, screwed back onto the rubber stopper, right? So new aspirating needle also for every patient prevents such accidental complications. So I've already told you about latex. It causes something like anaphylactic shock. Parabens, I have my own experience. So whenever a MR comes to you selling local anesthesia, it may not be Septodont. I'm not saying that buy Septodont, but read the ingredients. It is for your safety, because if it can happen to an oral surgeon after 20 years of practice, it can happen to any one of you, right? Why Septodont? Because it is an imported brand. It had to follow all the rules and regulations, right? And it is latex free, faster onset, so the patients don't feel the pain. Sterilization is excellent and there are no air bubbles. So there is no chance of emphysema. Many times in Indian cartridges, you have to exert force to push the drug inside. Why is that? Because there is an air bubble in that cartridge. So Septodont cartridges are better. You might think they are expensive, but where you have to use 3 Indian cartridges, you have to use only one Septodont cartridge. So in the long run, it turns out to be a cheaper alternative. So all these features can modify the parameters, can make or break you seriously. So don't take anesthesia loosely, choose wisely. Now in spite of all this, sometimes LA does not work. Why is that? Probably wrong landmarks, presence of pus, and patients who are smokers, pan tobacco eaters, patients on steroids like rheumatoid arthritis and all that, they have a tendency to be more resistant to any opioid or any anesthetic drugs, right? Because उनको high होने की आदत ही है, तो अपने छोटे एनेस्थीसिया डोज से हाई नहीं होते हैं. So you have to, what do? You can't give more than 15 ml. Patient will go into toxicity. So what you do is, you switch to another drug. First block with lignocaine doesn't work. Don't give a second block with lignocaine. Give the second block with articaine or bupivacaine. So what I do is, first block with lignocaine doesn't work, I will do intraligamentary with articaine. If that has not worked, then I will give complete block with articaine, and with bupivacaine I will give intraligamentary. 102%, 200%, then LA has to work. Other thing that works is injecting very slowly, because you don't want to give the injection in a shot that it goes straight into the circulatory system. You want local anesthesia, you don't want central anesthesia. So for local anesthesia, it has to go between the mucosa, the epithelium, the connective tissue, the fascia, muscle layers. So you have to inject very, very slowly, and the speed is 1 cartridge per minute. Our psychology and the patient psychology, patient is doing you say ho gaya, and khatak. 1 syringe is gone in 1 second. That is gone into the blood system already. Kuch farak nahi padne wala. Then you inject second time. Patient says second injection. Patient has already lost 50% trust in. Right? So better to be firm with the patient, right? But inject slowly and inject 1 cartridge of a drug which is effective. What do I do? Kaketu asked me yesterday, what do I drink? I told him I love cocktails. Right? So this is what I do. I love to make cocktails, I love to drink cocktails. So I give a combination of lignocaine in 3:2 combination. 3% of lignocaine I will use 3 cc for block, and 2 cc I will use for buccal infiltration of another drug and intraligamentary. In your cases, intrapulpal also, if you are doing cavity and you are doing root canal. Don't give intrapulpal with lignocaine. Give intrapulpal with bupivacaine or articaine with a different drug. Right? This way you have a long-lasting anesthesia, anesthesia which is working even in the presence of purulent discharge, and an anesthesia which is safely biodegradable. Alright? So what are the complications of local anesthesia? Syncope, allergy, anaphylaxis, trismus, hematoma. Paresthesia. Paresthesia can be caused either by wrong technique or by an overdose. Right? Don't worry, it is reversible. Right? It is completely reversible. It takes 6 to 7 months. You have to get married to the patient in that time, unfortunately. Right? But vocal anesthesia, then you have given local paresthesia hua, abhi vocal anesthesia use karo. Keep reassuring the patient. And this is a magic drug, methacobalamin. Neurobion 4 or meganeuron is the trade name. Give this drug. Twice a day for 3 months, the sensation comes back again. So now let's see how to tackle every complication. Before I go into complications, I have to tell you that all complications require immediate action. And immediate action is via intramuscular or intravenous injection. Nothing can be given orally that will take care of the complication. So if you do not know how to give intramuscular and intravenous, how will you handle a complication? So intramuscular is easy. Take the pelvic bone, right? on the dental chair only, ask the patient to turn over on the side. Loosen the sari pallu or loosen, just remove the belt of the patient. Feel the pelvic bone, the hip bone, right? Once you feel the hip bone, that is the superior margin. The end of the butt is the inferior margin. Divide the butt into 4 quadrants. The outer quadrant, outer and upper quadrant is the safest. Just below the hip bone, right? Just on the outside, almost on the waist. Hold that tissue with your left hand, perpendicular. The needle, 1-inch needle, perpendicular to the skin. It should go straight in, then it will be painless and it will go into the muscle. If you give it 45 degrees, it will go into the fascia and connective tissue. Patient, it will not act. And plus, it is like giving the periosteal injection. It is very painful to the patient. So it should be absolutely perpendicular. And pinch the tissue so that the needle doesn't shake. Pinch the tissue, right angles, in one shot, give the entire solution. Don't give it slowly. Intramuscular works, but it takes about 10 minutes, right? What is actually important is learning intravenous. Now, intravenous, it is a steep learning curve. It's almost like a plane landing. Here, you have to keep practicing. And how will you practice? Any patient where you do a long procedure, you start giving Boveran injection intravenously, right? And don't give painkillers on that day. Boveran works for 12 hours, right? So that way the patient will also not have any pain and you have also practiced. So here, what is the danger? The danger is that you inject with force, that the needle passes through the vessel. And never ever inject the needle with the medicine inside it. Take a butterfly, scalp vein. So, take a scalp vein, always use the forearm because the vessel is wider over there. You can see that greyness. 25 gauge scalp vein. The number to be used is 25 gauge butterfly. Bevel is up. Now you see the blood coming out. Hold the butterfly wings and now inject it at a moderate speed. Okay, now what will happen is that if you inject that syringe ka needle straight, it will go through and through like this, or it will hurt the patient. So always give this butterfly and you can put a sticking plaster over it, a bandage over it to hold it in place. Right? And always aspirate. As long as the blood keeps coming out, you know you are in the right position. These are the drugs which have to be there. This is it. Take a photograph. This is what all of you must have, and you may not have a complication for 3 years, 4 years. So it is important that every 1 year you refresh your emergency box. Otherwise, after 5 years when you have a complication, you will realize your drugs have expired. Right? So every year you refresh these drugs. I've made it simple for you what to use and when. See, when syncope happens, support the respiration. Now after COVID, everybody has a pulse oximeter in their clinic. So put the pulse oximeter. Check the pulse and the oxygen saturation. Oxygen saturation has to be above 90. Best way, what I have realized in my practice, is to splash water on the patient's face. Right? Don't even go to check BP, don't waste your time. Get ice cold water from the fridge, splash it on the patient's face, नाटक कर रहा है, syncope में गया है, उठ जाता है. Right? If it is genuine, he will not wake up with cold water. Okay? So don't even go taking out a BP instrument or checking or whatever. half glass of the water or with your 3-way syringe, just play holy with the patient. Okay? So that's the easiest way to check whether it is syncope. Pulse oximeter is below 65 nahi hona chahiye or below 90 nahi hona chahiye. Now lignocaine toxicity, when that happens, the patient starts talking too much, asking questions, very restless, starts scratching himself. Otherwise his head will have no control, his neck will have no control. It will be falling from side to side, right? And he will, just put his head back as though he's gone into a fit. What will you do? First and foremost, injection ABL, you will inject. If you do not know intravenous, intramuscular, that is too easy. Top and outer quadrant of the buttock, that is too easy. So just inject in ABL. That will take care if it is lignocaine toxicity. Here, this is what it is, that muscular excitedness and all that. Anaphylactic shock, what will happen? That is classic of anaphylactic shock. Lip will swell up. Lip will swell up, angioedema it is called. It will become pinkish blue. The tongue will swell up. Patient can't swallow. He'll feel like gagging. And when you tell him to open his mouth, you will realize his tongue has filled his mouth. That is classic anaphylaxis shock. What do you need to do over there? Injection hydrocortisone, that's a steroid. Any steroid will do. Hydrocortisone, dexamethasone, betamethasone, any steroid will do. Epcorlin, any will do. And ABL. If you do not know IV, give iron. But give. Actually speaking, when this happens, lignocaine toxicity, allergy, anaphylactic, we cannot understand what is happening, right? Other than syncope, on the dental chair, it is difficult to understand what is happening. First aid is important, so giving injection ABL and injection hydrocort intramuscularly or intravenously is very important. Then call the general physician and then call the hospital. Don't call your friends up. Patient is lying like this, I've given this, तेरे को क्या लगता है? Toxicity हो सकता है कि allergy हो सकता है? Don't do that. It is not your job to differentiate. It is the general physician and the intensivist's job to differentiate. If splashing water patient has not woken up, before checking the BP, before checking pulse oximeter, first thing is injection ABL and injection hydrocort. There are no side effects to injection ABL and injection hydrocort except drowsiness. Sone do patient ko. Let him forget that episode happened in our team. Okay? Right? So, ABL and hydrocort, remember your assistant should check every 6 months the expiry date and it should be kept close to. That will save your life and his life. Now, cardiac arrest. How do you know cardiac arrest has happened? After giving hydrocort and ABL, the patient is not revived though. The pulse, ox, it's below 65. This oxygen saturation has dropped and patient is showing no signs of movement. Right? That means patient has gone into cardiac arrest and you have 1 hour, golden hour, in which to call the ambulance and give first aid. So what is the cause of the cardiac arrest? All this because of local anesthesia, right? Anaphylaxis, obstruction because of a bridge or whatever might have gone into his lungs, a tooth or whatever, drug overdose, or already he might be having a myocardial infarct, apprehensive, and usko tumhara hi clinic mila, cardiac arrest karega. Okay? So these are the signs: chest pain, palpitations, sweating, tiredness, refusing to be revived even after giving injection ABL, injection hydrocortisone and oxygen. Alright, now after COVID, oxygen shortage, I'm sure everybody, you must be having oxygen cylinders at home or in the clinic at least. At least in Bombay, we all like crazy people went to the pharmacist. COVID किसी को नहीं था, but oxygen खत्म होगा और किसी को COVID हो जाएगा तो क्या? So we brought oxygen cylinders to our houses and stopped. Now we stare at them wondering what to do. Okay. So ऑक्सीजन ये सब होने के बाद भी पेशेंट अगर नहीं उठता है तो योर सेक्रेटरी इज कॉलिंग द एम्बुलेंस एंड यू आर गिविंग फर्स्ट एड, राइट? सो दिस इज द इनिशियल रिस्पॉन्स. सेकेंड रिस्पॉन्स इज दिस इज व्हाट यू विल डू. नाउ हाउ डज वन डू दिस? Right? There is this thing. First, drag the patient down from the dental chair onto the floor, right? On a flat surface. Bend right angles over the patient. Loosen his shirt. The our fingers don't have any pressure. Heel of our hand has pressure. So heel should be at the first rib between the two breasts. Exactly between the two breasts. On top of that one hand, you will link your fingers and place your other heel. Okay, the palm of your hand. And then all your body weight you will put on that linked palm and you will start giving compressions at the rate of 30 compressions, 100 compressions per minute. Means it's quite fast, right? You are not doing slowly. If you are delicate and you cannot do it, get your assistant to do it, a male assistant to do it. Ki dabate ja, right? And in between what you will do, you will tilt his mandible up, open his mouth and breathe into his mouth. Why? Because carbon dioxide, it ignites the CNS and causes the patient to breathe. Carbon dioxide at this time is required. So you will tilt the mandible, not like this. Tilt it so that your carbon dioxide goes into his airway, right? And you will breathe into the patient's mouth 3-4 breaths till you actually see his chest rising. So that's why you must remove the patient's vest and the shirt so that you come to. In case of a female, remove the dupatta so that you can see the chest rising up and down, right? Remove it, look from that lower level at the chest. ऊपर से देखोगे तो आपको पता नहीं चलेगा कि chest move हो रहा है. But if you look at an angle, you will see the chest moving slightly. That means the patient is getting revived. So, repeat the cycle of 30 chest compressions followed by 2 rescue breaths. Right? So, thak, 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 thak. 30 times you will go at high speed, all your body weight onto it. Right? And after 30, you will breathe heavy breaths like pranayama into the patient's mouth twice. Again start beating and the patient will definitely get revived. He won't be able to stand up, but then what do? Turn the patient over on the side, slap his back, make him cough. When you make him cough, right, you are introducing cardio activity. Right? That is what is required, cardiac activity. So make him cough. Tell him keep coughing until then the ambulance comes in. Once the patient is taken to the hospital, then defibrillation, intubation, intravenous line, sodium bicarbonate, everything is done. But your job first is पानी फेंक. नाटक है तो पेशेंट उठ जाएगा. पानी फेंकने के बाद पेशेंट नहीं उठा, what will you inject? What will you inject? Abil and hydrocortisone. Intravenous नहीं आया, intramuscular. फिर भी पेशेंट नहीं उठा, Then take the BP pulse oximeter. That is below. Start chest, drag the patient down on the floor and start chest compression with rescue breaths. Right? So these are the steps to revive a patient. This is the golden hour. If you delay in this, if you run to make a call to the hospital, no. You have to stay with the patient. Your assistant will run to call the hospital. Right? Your focus should be entirely on the patient. Now, LA gives Christmas also. Right? Why does LA give Christmas? Because when you use the same needle, that bevel gets bent. Or if you hit the needle to the bone very hard, 2-3 times, the bevel gets bent. And when you withdraw the needle, the bevel injures the longitudinal muscle fibers. There is bleeding within the tissues. That blood clot within the tissues causes the muscle to go into a spasm. And that is why the patient gets a trismus. So don't panic. Hot salt water gargles, right? And if the patient is very scared, keep this stretcher with you. Put the stretcher in the patient's mouth. Open it once. Once that lock is open, he will find it easier to open subsequently. What is hematoma? Basically collection of blood in the soft tissues. That happens if you have punctured a blood vessel, right? And there is a bubble in the blood vessel or there is a clot formation in the muscle fibers. So use aspirating syringes and don't suture too tightly. If you suture too tightly also, all the swelling, edema goes backwards into the spaces. It doesn't drain into the mouth. So suture just loose enough that there is approximation but tissue is not squeezed. Infection can happen, lack of sterilization, asepsis, contaminated solution using the same needles, and patient's low immunity also, right? So symptoms will be abscess, fever, chills, right? When the patient says, I have got fever and I am shivering, means understand you need to change the antibiotic, the patient has got infected. Edema is, many people feel edema is because of lot of bone removal. Bone is never the cause. Bone removal will cause osteomyelitis, it will cause dry socket, but it will not cause swelling of soft tissue. Swelling of soft tissue, the cheek, it is always because you have retracted the soft tissue very harshly by your retractor or your mouth mirror. That always happens when you give the retraction to your assistant. और दिखाना, मुझे कुछ नहीं दिख रहा है, कुछ नहीं दिख रहा है. You would say that assistant का क्या अक्कल है? Like this he will put the cheek. And the next day the patient comes with a huge swelling. So it is very, very important that you must retract very gently. Take care that there is no infection and no bleeding by the time the patient goes home. So the patient should be kept in the waiting room till the gauze pack is white, pressure pack, and then the patient should be sent home. Pain, always when you use thick needles, always understand for dental procedures it is 25, 26, 27 or 30. Nothing less than 25. 25 is also thick. Ideal would be 27 and 30. Alright, and inject slowly. Broken needles, they break because you are jiggling from side to side. If they break, you please don't try to remove it. What you need to do is first send the patient to a OPG clinic. See where the radio opaque needle is. Accordingly palpate take an incision over the needle and then take the needle out. Right? Without an X-ray, never try to take the needle out because the needle will twist and turn into the tissue. Paresthesia can be caused by LA and injection, but rare, very honestly. Right? Or it can be caused by overdose, that is if one goes about 16, 17 cc's of the same drug. Understand the difference. If you give 6 cc's of Articaine and 5 cc's of lignocaine, there will not be a toxic overdose. But if you give 15 cc's of lignocaine or 15 cc's of Articaine, there will be a toxic overdose. Right? So therefore always mix drugs. Again, meganeuron on neurobion 4, that is a wonderful mix. Now sometimes you go to give an intraorbital block or posterior superior alveolar block, usually posterior superior alveolar block, you will enter the parotid gland. Parotid gland contains the facial nerve and you will have facial palsy, you will have drooping of the eye and you will wonder where you go wrong. So take it from me as a blanket rule, you can give inferior alveolar nerve blocks, you can give infraorbital blocks, you can give nasopalatine blocks, but for heaven's sake don't give posterior superior alveolar blocks. Give infiltration only, because PSA block can cause facial nerve damage, facial palsy, crossed eyes, because the needle has entered the parotid gland and parotid gland is of different shape in different patients. And it can cause a huge hematoma here because the needle has gone too high up and hit the pterygoid plexus of veins. So there are two dangerous organs where PSA block has to be given, parotid gland and pterygoid plexus of veins. I have suffered both in my clinic, right? The patient for facial palsy had to undergo physiotherapy sessions. He became better, but I became famous, right? I wanted to be popular, I didn't want to be famous. I became famous, infamously famous, right? And it was in a doctor's mouth only. She came with the upper root piece, upper 8 root piece, overconfidence. Oh, upper root piece conical, I can do it. And while talking to the husband who was sitting opposite, he was also a doctor, super confident in me, my elevator slipped and it went up and hit the pterygoid plexus of veins. The patient had this huge hematoma here for about 1 month. So there also I became famous. Okay? So PSA is extremely dangerous. Don't give that now. Allergy, like I told you, it is because of latex or paraben, injection avil, oxygen and hydrocortisone. Right? I prefer cartridge, right, because those are any day safe. Now let's sharpen our basics, right? It's all everyone tries, everyone thinks it's so simple to defeat BJP and Modi, but it's become one of the most difficult tasks for the opposition to do, right? Who's in Nagaland? Which party? Coalition. BJP coalition. I belong to a WhatsApp group. There is a Kurukshetra war every evening. 50% BJP, 50% opposite, anti-Hindu, and it is, I don't need to read the newspapers. Whatever Modi does, I come to know on the WhatsApp. Whatever the opposition does also, I come to know on the WhatsApp. Right, so it's like that. So extraction, it's actually everyone thinks when earlier senior doctors used to call me for referral. I used to do visiting when I was junior. They used to say, हाँ अश्विनी, सीधा है, 5 minutes में निकल जाएगा. I was junior. I couldn't tell them that, sir, what sir, you have not diagnosed it properly. It's multi-rooted, it's dilacerated, it's going to need surgery, right? So they used to feel extraction is simple, but it is actually to be done very precisely, very painlessly, and that is the procedure a patient is most scared of. So what are we looking at? We are looking at crown fracture, root fracture, attacked gingiva, dental papilla getting disturbed, then recession, bleeding, बाजू का दांत ऊपर आ जाता है, right? So how do we avoid? First is instrumentation. Very, very important. Periosteal elevators are a must. Which is the best periosteal elevator? Please invest in it. P for Pune. 14, 14. P14 Ufred. That is the best periosteal elevator. It is thin, it is lovely concavely shaped, and it is sharp enough to reflect the tissue. Right? P14 Ufred elevator. Forceps. Don't buy fancy forceps with angled handles and long handles and very stylishly. Doctors tell me, Ashwini, ye third molar ka de le. I don't know where the tip is. The handle is only curved like this. Right? So don't buy all these fancy handled ones. Cow horn is the best. Why cow horn? Because when you go to take the tooth out, if you end up breaking the tooth, cow horn ends up fracturing the roots. So then it becomes easier for you to take the roots out separately. If you use a normal molar forceps, what is going to happen? You are going to crush the crown. And then the root is going to be at bone level. And then you are going to be wondering how to take it. Okay, so cow horns only. Other thing what you should do is, don't use winter cryers. वो triangle वाला and Epixo elevators to remove root tips. Always use hospital elevators. These are called hospital elevators. Warwick James hospital elevators. They are concave and they have a rounded tip. So they don't scrape the buccal cortex or the lingual cortex, and they don't cause bleeding. So always root elevators should be hospital elevators or Warwick James elevators. For removing root tips, luxators are important. Abhi luxators ka bhi 1000 company hai. Please invest. The best luxators are Directa. DIRECTA. They cost 3,500–4,000 one luxator, but that one luxator has lasted me for 15 years. I purchased one JDC luxator, first patient only, the thing twisted, right? The shaft twisted. So please buy luxators the way they should be strong. Directa. 3 tips for breakage free. Always elevate and loosen in the direction of the long axis. So whichever way the root is curved, you will try to bring the root out in that way only. Don't go the opposite way. Always, once the tooth is moving in a downward motion, then clockwise and anti-clockwise rotate and loosen. Then move it buccally and take it out of the socket, because the buccal cortex is always the weakest bone. In palate is not going to give way. Even in lingual, the lingual cortex is very strong. So always move the tooth buccally, right? Swing it outwards and rotate it. When you go home and enter your clinic on Monday, always check elbow movement of the forceps. This will be easy because your forearm muscles don't get tired. If you are using this gets tired and suddenly you give a jerk and attack, the tooth breaks. So it should always be elbow movements. But for elevators, wrist movement, your elbow will be steady. Wrist movement, clockwise, anti-clockwise for the elevators. always separate the attached marginal gingiva with the tip of a wax spatula or Moon's probe. I don't prefer the Moon's probe. I prefer the wax spatula, but separate spatula from prosthetic purpose. Keep it separate for this. And forceps must grip below the level of CEG. Right? If you only hold the forceps, the crown, then the crown is going to break. Which is the weakest part of the tooth? It is the neck. It is the CEG. It is going to break at CEG. So you should separate the attached gingiva. You should be able to see the cementum. You should push the forceps in and make sure the tip of the forceps is resting on the root and then swing it buccally. Alright? See, this is how you should separate the gingiva so that you can see the CEG. How will you see the CEG? Forceps push karna hai, kahan push karna hai? So you have to separate the gingiva completely, separate the dental papilla completely so that you see the CEG and you see the furcation. And after you see the furcation, then you will again elevate by taking a good grip in the interdental bone on the mesial surface of the root, right? Not on the distal surface. And always understand, keep 3 elevators. Don't invest in forceps. Thinnest elevator should be to gain access. Arrowhead elevator, you get it in Golden Nimbus, Bombay, online. That is to move the tooth. And if the tooth is stubborn, then you use a broad elevator. What is important? Each of the elevators should be concave, like this, like a spoon. Don't buy elevators which are flat. If you buy elevators, the mic is not working. If you buy elevators, hello, which are flat, they are not going to serve the purpose. So when you are selecting elevators, check that they are concave. The deeper the concavity, the better the action. Take a power nap of 20 seconds. I hope this is not a basic for you, please. Bear with me, this was the topic I was given. Right, so understand that was okay, it's come back. Forceps do only 20% of the job, right? You have to crush the buccal bone, it's okay, but don't hold only the crown. And root removal should be done by section. See, this is how the forceps should hold the tooth, right? It should go near the furcation. It can't be only on the crown. And that's why I prefer to use cowhorn forceps because it goes below the furcation. Right now, root tips. How do you remove root tips? Divide and rule. Just section it. In this, I couldn't even see anything. So I took a flap, use a air rotor burr, divide the interdental bone through and through. How will you know you have gone through and through? Because your burr will face resistance as long as it is in the tooth. Once it goes through the tooth, into the bone, into the cancellous bone, your burr will just sink in. So then you know you have successfully sectioned the entire tooth. Push your Warwick GM's hospital elevator in the interdental space. Remove your mesial root. Push the other side, other elevator into the mesial socket. Remove the distal root. Now can you see my buccal cortical wall, the height is intact. So after 2 months, I can very well place an implant here. Right? So this is how you section it. Now for premolars, what you will do, you will make interdental grooves here, where the pink is. Right? With thin cylindrical burr that will be number 700 SS white carbide on a straight micromotor, or it will be a air rotor burr. Tapered fissure. I'll show you which one. And many of you all feel that you can't use air rotor in surgery, right? It causes emphysema. Let me tell you that emphysema is caused when there is no suction, when you have taken a huge flap, the pterygomandibular space is exposed or something like that. So just feel free to use the area. Very nice. Guys, don't run away in the darkness, huh? AC person strong. Any doubts so far? Or were you sleeping?
We are learning along.
Any doubts about anything? I wouldn't want you all to think that I was pushing only one company. I have tried to be fair and I have tried to tell you about the techniques, and I have used a lot of anesthesia, and I have realized that it is better to be penny-wise rather than pound-foolish. And I have also realized after using patients that how easy it is to lose your reputation with just 2-3 mistakes in spite of doing hard work for last 10-15 years. Right? So for premolars and anteriors, remove interdentally. In no way when you are extracting a tooth, cut buccal or lingual cortex, because that is what will lead to a bad aesthetic outcome. Right? Because once that recession happens, then even if you are doing crown and bridge, you have to add pink material. Right? So always maintain the height of the buccal cortex. The tooth extraction can be done by sacrificing the interdental bone, right, and nudging the tooth out with the luxator. For maxillary molars, those are the most difficult, and sometimes I hate endodontists, because these days with new endo techniques, you all are doing such fantastic jobs that oral surgeons start crying when it comes to extracting those. Right? Post किया है, core किया है, re-RC किया है, crown किया है, सब कुछ किया है, सबसे difficult काम हम पर छोड़ रहे हैं. Right? And the caries has reached right till the apex, and I am supposed to take it out without sacrificing bone. So that is what you do. Reverse T incision. Reverse T. Separate. Again here you will use a air rotor burr, which I will show you. You will separate the mesial buccal cusp, distobuccal cusp, and the palatal cusp. This is how it will be. Right? Then in the center here, you insert a straight elevator and twist. So the 3 roots become separate. Then put your bayonets inside and take every root out separately. So for a maxillary upper molar, this is how it will be, reverse T. And for a mandibular molar, this is it will be, the cut will be through and through. Don't stop here. It go through till the bone. Okay? Even in a premolar, you can section through and through, take the buccal fragment out first and then take the palatal fragment out. This is how it should look, right? No disturbance of the attached gingiva. Then pack it with gel foam, take sutures. Now when it is a tooth, right, there will not be perfect closure. Don't stretch the gingiva to get perfect closure. You will lose attached gingiva, right? This much space is sufficient. Why have I given sutures? For the periosteum to touch the bone and for the gel foam to stay inside. But if I stretch this to close it like this, I am going to lose my vestibule. So don't do that. Let there be a gap for the attached gingiva to grow. Now this is important. Please take a photograph of this. You will use only this burr for section. Comet's long shank. Why will you not use this cavity cutting burr? Because when you go to section, the head of your handpiece will hit the neighboring tooth and your burr will not go in the bone. It will end here. You understand what I am saying? Because the head of your handpiece is touching the adjacent tooth, your burr is ending here, the tooth is not getting shaken completely and you are having a problem. So all your sectioning should be done with Comet's long shank surgical carbide burr. It's for air road, right? And now when there is perioapical radiolucency, cure it, otherwise good bone won't form. There will be such a breakage, right? When there is such a breakage, what will you do? You will take a flap and you will either remove bone from the sides or you can try a file or a reamer, push it inside and jiggle it, that small apex will come. Okay? Now when do you leave roots behind? You don't have to take out roots every time. If this is the case and it is so close, then just smoothen the sharp edges of the root, put a gel foam and suture. Leave it behind. Don't try to take out and cause paresthesia. Tell the patient your tooth was very close to your nerve. I did not put it. It was a very abnormal situation in your body. So I have decided to be wise and for your sake I am leaving this root piece inside. Nothing will happen. If anything will happen, come to me. Right? Also understand, if there is infection, the patient has infection, there will be a radiolucency around the root, then in that case the root will not be so tight in the bone because there is bone loss because of infection anyways, right? So when there is just a pericoronal or a decay which is not reaching the apex and you leave this behind, the next day the patient will not feel any pain. Don't panic. The pain which the patient feels the next day, it is not because of the root piece that is left inside, it's because of the extent of the surgery. Right? But what is important is that you smoothen. You smoothen it flush with the bone. Don't leave any sharp edges. Right? And in a maxillary antrum, if that palatal root piece is going to cause a oronasal fistula or oroantral fistula, leave that. Nothing is going to happen. You lose an implant case, put crown and bridge. Okay? Now ankylosed tooth is when you try with all your mouth but the tooth is not moving. Then just divide. Even if it's a whole tooth, divide it. the way I told you about root canal. For future implant placement, like I told you, always section interdentally or centrally through the groove, but leave the buccal and the lingual cortices intact, the height intact. And you can do socket preservation, right? Place bone graft inside, collagen membrane on top, TRF membrane on top, and then suture. Right? Suturing will not be like this. There will be a gap because there was a tooth there. Attached gingiva will grow it. Perfect extractions should look like this. No damage to the bone, and you have placed implants immediately. Alright, now coming to complications. How do you avoid trouble? Broken tooth, elevate thoroughly and use only cow horn forceps. Intra-op bleeding is only because of periosteal disturbance. So take a clean flap, use a good periosteal elevator. Secondary bleeding happens when you haven't rounded the bone margin, or when there is amalgam debris or bone debris or a bone chip inside, then it dislodges the clot and secondary bleeding happens. So flush the socket before suturing. Dry socket, I'll come to it in detail. Paresthesia, I've already told you. Dislocation of the condyle, always support the mandible when you are taking a upper or a lower tooth out. Fracture angle mandible is when delicate patients come and they have got long roots and you have not elevated and you have used only the forceps. Then fracture can happen, so always elevate. Now, management of bleeding. Socket bleed, bone wax. You get Ethicon as the company. You get bone wax. Just push bone wax into the socket. The bleed will stop. Push gel foam, pressure back. If it is soft tissue, then you can use a cautery. If you don't have a cautery, you can use a heated ball burnisher also. That too everyone must be having for root canal. The projector requires speed. So mucosal injection of what did you use? Yeah, like Stadrin or ethancylate. Just inject 2 drops around the fat. Edema, give Bidantin port or chimeral port. You can give steroids, but I prefer oral steroids. I prefer to give an intramuscular steroid because oral steroids cause a lot of acidity. Hematoma is, you please stand there. Hematoma is when the next day the patient comes to you and opens the mouth and there is a transparent orange colored liquid coming out of the socket, right? And that can be because of collection in the soft tissue.
Madam, can we have the back side?
Yeah.
Let
him. This one?
Yes.
Yeah. Right, so like I told you, hematoma, it's very common with PSA blood. Don't go there. Also very tight suturing. So, especially in a third molar extraction. So that buccal stitch is there, na? Don't give that buccal stitch. When you do a third molar extraction, you have a vertical incision, right? Near the 7th. So don't give the buccal stitch. Just do distal to 7th and up of the ramus. And patient to apply ice directly, what happens is frosting. The blood clot that happens, it becomes hard. So they should use cold towels or wrap a towel around the ice pack or ice cube and then apply it. Ecchymosis is this type, right? When the patient comes in, that's because of capillary bleed or too much ice application. There is only one cure, that is thrombophob gel. No other cure. Trismus, it is basically the muscular fibers going into a spasm for two reasons. The patient kept his mouth open for a long time. Second reason is injury to the patient's fibers during injection of LA. So, alternate hot and cold fermentation and moisture. Now, dry socket, it takes 7 days to heal. How do you diagnose a dry socket? After 3 days, if the patient comes to you with pain, then it is dry socket. Patient has no swelling, no fever, no chills, no bad breath, no pus. But the pain is not good. And the socket is blackish in nature. Then it is dry socket. If the patient comes with fever and bad breath, then it is infection and he requires antibiotics. But if the patient comes with just a dry socket, don't prescribe antibiotics. Don't cure it vigorously to induce bleeding. What you do is take betadine solution, forcefully flush the debris out of the socket with betadine and hydrogen peroxide diluted solution. Check whether there is any sharp object, right? Smoothen that sharp object, then the flap edges would be very ragged. Cut them with a scissor, make them sharp, right? Then make a zinc oxide eugenol pack, right? So simple zinc oxide powder with alveogel fibers. The alveogel fibers are cotton fibers mixed with betadine for antibacterial and antiseptic. It contains benzocaine for anesthetic action, right? So these two are the factors which lessen or deaden the pain completely. So you don't need to use eugenol. Eugenol is already there. So just the fibers and the zinc oxide powder, make it into a pack, shape it into a nice sausage and pack it into the dry socket. This is how it will look. Don't remove the pack. As the wound heals from bottom, right, the pack will come out by itself in about 3 weeks. But patient's pain will go away. Alright? So this is the only treatment for dry socket. If you have plasma-rich fibrin, the machine with you, excellent. Then there is dry socket kabhi form hoga hi nahi. You should pack plasma-rich fibrin in every extraction socket. But if you don't have plasma-rich fibrin, then to avoid dry socket, always irrigate. Don't allow the bone to be heated. Flush the socket, right? Be gentle with the tissues. Alright? Those are the 3 tips. Trismus due to dry socket, again, jaw stretcher and exercise. What I make the patient do is this. He's scared. He's not opening his mouth.
Once, but after do this. That's it. Close.
Still he won't open.
Open mouth. Close. Open. That's it. Close.
Look at his face. He's suffering right now. But next day he was quite happy.
Open.
Then you tell him eat pani puri, eat laddu, eat burgers, stop eating rice and kheer, stop eating ice cream. So you have to open and make him do those exercises.
Great. Now go back to normal diet.
Right? Do this. Otherwise the patient will not do it. And I tell the patient, now my treatment is over. It is in your hands. If you don't open your own mouth, I will have to take you to the hospital, give you anesthesia Cost will be 50,000. 50,000 darke, the mother only starts saying, open your mouth, open your mouth. Okay, so when do you call a surgeon? I'm not a quitter, but sometimes it is wiser to call a surgeon. Right? Don't be in a hurry. Take your time. Now, when do you stop bleeding? How do you stop bleeding? Immediately take adrenaline ampule, break it, soak cotton into it, put it on the patient's socket, ask the patient to bite. The bleeding will stop in 5-10 minutes, right? Then it will start again, but you will come to know whether it is from the soft tissue or hard tissue. Okay? Don't send the patient with adrenaline pack. Hypoglycemia, glucon-D. Right? Diabetic patients, the procedure has gone for a long time, they have not eaten anything. So, glucon-D. Hypertension, you will see it is bleeding. The extraction socket is going on bleeding. Check the BP. Always buy a digital BP machine. It does give accurate ones. Don't buy the manual one. Keep nifedipine with you. 5 milligrams. Squeeze it below the patient's tongue. Right? The BP comes down to normal. Patient is also less apprehensive. Right? Hypotension, you can see those patients. They are these delicate ladies, you know, who are short, very pale, anemic. So their BP falls. Right? Again, glucon-D, and if the patient is still feeling weak after glucon-D, give a steroid shot. Right? First trimester, please avoid any treatment. Second trimester, safe to perform every treatment with local anesthesia and adrenaline. Unless the patient has high BP, then without adrenaline. Third trimester, don't touch. You will induce baby, right? So don't do that. And which are the drugs which are allowed? Cephalosporins, amoxicillin and Dolo 650. Lactating mothers, augmentin, and surprisingly, diclofenac has the least secretion in breast milk. So you can give Voveran, right? For stronger pain, tramadol and Ketorolac. Thyroid disorders, tell the patient to take the thyroid medicine and come. Liver cirrhosis, you avoid Brufen type of drugs. Brufen, Voveran, only tramadol or paracetamol. Right? Renal dialysis patient, you have to take the permission of a nephrologist because patient has to be given vitamin K tablets or vitamin K injections before you can do the dental surgery. Bisphosphonates, I wait for 6 months. G6PD deficiency, it's usually seen in Parsis. We have a lot of Parsis in Bombay, so we have to avoid ibuprofen. That's a bleeding disorder. Cancer treatment patients, post-chemo, but better to take advice of the treating doctor. What happens in post-chemo and post-radiation? Dry socket to 100% hoga. Right? Delayed healing, oral ulcers 100% hoga. Because the immunity is below 0. Right? And they have no control. Their muscle weakness is quite a bit. So you have to give them chlorhexidine gargles. And you have to tell them gargle every hour so that will stop infection from spreading. Now, don't try to be James Bond, right? Bleeding disorder. Someone comes to you saying, I've got hemophilia. Send the patient to your neighbor, right? You don't do it. Cardiovascular status. Last week, मेरा bypass हुआ है, मेरा दांत दर्द हुआ है, right? Send it to the hospital. You don't try anything. Immunological psoriasis patients, other immunological complications, don't spoil your practice and your mental well-being. It's not worth it, right? Because all this, if they go wrong, they can create havoc for you. Your best friends should be a GP, who will advise you which drug to give. A general surgeon who will help you. ENT, your colleagues and a mentor. Their numbers should be on speed dial, not girlfriend or boyfriend or mistress or master, right? And leave your ego outside the operating, right? Don't keep trying for 2 hours, 3 hours. मैं कर सकता हूँ. Immediately call somebody. You don't have to tell the patient that I don't know how to do it, so I'm calling a friend. Quietly tell the patient, just rest for 5-10 minutes. I want you to rest. You go outside, you call whoever you want to call and say, okay, are you fresh now? Come on, let's do it. So put it on the patient that you gave the patient the rest, right? And then take the help of the colleague and do it. And don't ask dumb questions like to your assistant. उधर से तेरे को दिख रहा है क्या? Can you see from that side? I can't see anything from this side. Okay? All these dialogues shouldn't be done in front of the patient. Right? Patients say, I'm nervous. My favorite sentence is, patients are always nervous because it is their first time. You have to be really nervous if it is the doctor's first time. Ask me, is it my first time? It's not my first time. So then why are you nervous? Right? So like that you reassure the patient. And we don't have to be butchers. We have to be healers. We don't have to be surgeons. We have to be healers. So an excellent surgeon actually says no more times than yes. Because every surgery has collateral damage. So thank you very much. These are some of my experiences and classes. I love teaching. These are my contact numbers. Please feel free to get in touch with me for any problem. Right? Let me thank my family. My 2 daughters, one is in Chicago, one is in Germany. I'm looking for a boy for them. Anybody ready? Pre-made oral surgeon, mother-in-law. Okay? I love representing India abroad. They all have a wrong image of India. I want to show them what real India is. And we all can have it all. A should stand for ambition, L for learn, L for love yourself. And I'm really, really proud of my country. I wouldn't want to settle anywhere else. Thank you. Thank you very much. I'll get it.
Very. A very big thank you to Dr. Ashwini. Indeed, it was a very wonderful presentation. I'm sure that we all have benefited through this session. And if God willing, even on the days to come, we look forward for your presence. And I hope and expect that we'll learn more in the days to come. And once again, let's just give a big round of applause.
Thank you. Thank you for not walking out. I appreciate it.
Now, I would like to give time to our President, Dr. Raketo. We can take the show.
if I give a break? Can't take this break? Because those kind of long sessions, so maybe you can use the restroom. 5 minutes break.
तो इतो थाका से इंडियन डेंटल एसोसिएशन नागालैंड स्टेट ब्रांच लगा 18th कॉन्फ्रेंस जनरल मीटिंग कालीब्रा शुरू करिना आज 2 दिन हुई आगे प्रोग्राम लुई थाका निशना इता भी अलग सेशन जारी जायसे मोकान इता दिखा एकता रिसर्च पर्सन कुन डॉक्टर भी आसे डॉक्टर अश्विनी ताइबा आइगना कोथा करिना ताति कुन मानुकान रिसोर्स पर्सन कान थाकिसे सब भी एन्जॉय करिना थाका आसे तो इता ताकन एकता ब्रेक लइसे तो इतुला बुलेटिन काने इमाने आसे आरो अलग अलग खबर काने साइता बे ऑन बिल टीवी गुड बाय
'सुगंध, रंग और असली झांस एवरीडे जुबा पे अपना स्वाद एवरीडे स्पाइसेस 100% टेस्ट एवरीडे स्पाइसेस बेस्ट सुगंध, रंग और असली झांस एवरीडे जुबा पे अपना स्वाद एवरीडे स्पाइसेस 100% टेस्ट एवरीडे स्पाइसेस बेस्ट याद रहे अच्छे से होना चाहिए आयोजन
एवरीडे मसालों से टेस्टी बने भोजन
एवरीडे स्पाइसेस 100% टेस्ट Everyday Spices best.
In 2019 day, Ministry of Social Justice and Empowerment Kanpra magnitude of substance use in India report published kurise aru itu report ma janishe ki alcohol do sabse common substance of abuse ase followed by marijuana and opiates aru India de 14.6% do alcohol laga current user ase aru itu to 15 crore manu punche Tripura aru Arunachal Pradesh de substance abuse laga sabse bishi prevalence ase Our result laga hesab te scheduled tribe population they drug or substance to high probability ase. Societal pressure, changing roles, lifestyle changes laga stress ra manukan ke drug or substance abuse to vulnerable kurinde ase. Notice the lack of opportunities and employment development or border area ra drug source kura karni notice manu vulnerable ase. Notice the lack of opportunities and employment development or border area ra drug source kura karni notice manu vulnerable ase. Substance or drugs abuser bishi societal discrimination face kure aro tai kan laga health or safety bi affect kure. HIV transmission or drug use bi bishi strong link ase. Notice that the HIV epidemic drugs used for a bishi spread hoy ase. Department of AIDS Control Ministry of Health and Welfare laga report pra kwado HIV and AIDS Manipur and Nagaland laga prevalence 1.5
Amikan laga kordo saba rakhule monjai idu nishna amikan kile amikan la surroundings kan saba na rakhe एक बार भाभी सभी आमी खान किले आमी खान लगा सराउंडिंग्स तो सफा रखी बोले इफोर्ट न दे अरु मनु अलग खान बरा लेतरा कुरा दम दे किले ना रुकाई आमी खान होता ही DMC खान के रिस्पांसिबल दे होसा असे ताई खान लगा दास असे आमी खान लगा सिटी क्लीन रखी बोले होले भी आमी खान लगा सोशल रिस्पांसिबिलिटी तो खुद असे डिमापुर म्युनिसिपल काउंसिल खान बरा क्वादो ताई खान भी डिमापुर सभा करे बोले विगियसली काम करे से Holibi taikan laga side de bi shortfall ho jai, especially marketplaces area khande. As a citizen, amikan laga duty ase amikan laga city do sabara kibule. Under the banner of a Better Dimapur project, TMC Canberra like-minded groups or institutions such as Team Clean, Dim Green, Living for Environment, Life NGO, Healthy Dimapur, or Act of Kindness, or Dismantling Team kan logote partner kurikina kam kuri ase Dimapur sabara kibule. Sapa kuria laga aro alag-alag activities kan bi bishi alagina kam kuri ahi ase daikan laga modud para. Aro public spaces kan debi metal dustbin bi install kuri digina ase aro trees kan bi blend kuri gina ase dividers kan de Dimapur city do sundur aro green dikhepule. Kindu daikan inika bhal kam kurile bi public kan bara individual responsibility in maintaining public hygiene aro cleanliness do idyabi bishi komti ase. Manukan habituated hoishe letera do daikan laga khushi jaga de phikabole. Dimapur do one of the fastest growing cities ase northeast de idu nishna garbage volume do hodai din increase hoi jai ase aro idu nimide TMC kan bi public laga corporation na thakya do taikan kane bishi duk ase. Swatch Survekshan 2020 cleanliness survey de Nagaland do rank 9 de thakshe aro idu bidor de Dimapur aro Kohima do sobse dirtiest city laga category de thakshe. Out of 382 cities, Dimapur do rank 375 de thakshe. Aro report hisab de Dimapur do garbage generation do hodai din uthi ase around 1 lakh kgs or 100 tons per day bara. Aro report estimate kura de garbage generation do pishi increase ho ase by 15,000 tons per day bara. Dimapur do Nagaland la commercial hub ase hulbi citizen kan laga lack of civic sense kan saigina pishi soram ase rasta sob teletera kan kinar kan de pikai gina ase aro amikan hodai din dikhe. Amikan laga city do sabara kibule ki kuribo lage. Amikan letera kan rasta de ne pilawo lage aro dustbin de hi pilawo lage. Amikan cleaning staff kan ge support kuribo lage. Amikan trees kan bi bishi blend kuribo lage. Reusable water bottle de invest kuribi. Plastic kan bara tak avoid kuribi aro shopping gura time de nijor laga bag loi jabi. Amikan itu gura shuru hoishe gole amikan laga part de manukhan ke inspire bi kuribo aro bhal example bi set kuribo. As an individual amikan laga oborde bi bishi ase differences anibole aro ekilo milai gina dunya to bhal banawole.
We aren't those who only point the fingers, but also raise the issue.
We take questions to the right places.
We bring you facts and figures.
We write a new tomorrow on the pages of the future.
Northeastern India's new voice, new change.
Trusted news channel of Northeast India.
Voice of Emerging Northeast.
We are Hornbill TV.
আজিকালি লাগা বাচ্চা আৰু adolescent kan traditional আৰু নতুন forms of digital media de bishi immersed হৈ যাইছে 10 সাল মাজতে মই kan দেখি পাই কি digital media use to মই kan para interactions